Hi, Ari.
Hi.
Hello.
Hi, how's everyone doing?
Great.
Yeah, great. We are going to wait one more minute and see if other people join us because I just switched and there were still a lot of people in the main room trying to figure things out. So let's give them a couple of minutes and then we'll start. Where are my panelists?
I'm right here.
Hi, Dr. Chivas, how are you?
Buenas tardes, todo bien, gracias.
Qué bueno. Oh yeah, there's a lot of people already unassigned, so they're probably trying to figure it out. Okay, so it's 2:06, and because of time, we only have 1 hour. We are going to go ahead and start. So let me introduce myself. My name is Aaron Alarcón Bowen, and I'm currently the Bureau Director of Community Services Bureau of Contra Costa County. And you guys are probably gonna think, what is somebody from Contra Costa here moderating a group of in aging in Marin County? Well, I spent 7 years as part of Marin County government, 3 years as a program integrity coordinator for in-home supported services, and the last 4 as the executive director of the in-home supported services public authority. It was a great opportunity that helped me grow professionally, and most importantly, gave me the honor and the privilege to work for vulnerable populations in Marin County, older adults and individuals with disabilities. Right now, as I said, I am leading the Community Services Bureau of Contra Costa County. And what does the Community Services Bureau mean? We are my Marin County calls it divisions. Contra Costa County calls them bureaus. And we are a bureau that oversees all the early childhood education efforts of Contra Costa County. And by that, I mean Head Start and Early Head Start. I have under my jurisdiction 13 county affiliated and county managed childcare centers from ages 0 to 5 for low income families and children. We also have 19 community partners that we either totally or partially fund. I also have under my purview the community action efforts of Contra Costa County, and those are the efforts that are geared towards alleviating the effects of poverty. I went from being the director of an agency, a smaller agency. We were like 5, 6 people, and now my bureau has over 400 employees. So my day is very, very busy, but I'm super excited and honored for this opportunity. And I'm even more excited that Linda Jackson invited me to be part of this convening. This is, I think, in my 6th or 7th convening that I have attended. So coming back to Marin County is coming back to family. So Let's now meet our panelists today. We have three great panelists that come from very different perspectives and who are experts in the disparities of older immigrants in our county. So why don't we start with Dr. Chibras, and I'm gonna ask that you please tell your name, where you belong to, and if you can share with us what is the #1 professional achievement of your career so far. Dr. Chibras, please.
Welcome to everybody, and thank you so much, Aaron. I really appreciate that, and thank you to everybody who's listening. My name is Jose Chibras. I'm the Chief Medical Officer for Marin Community Clinics. I'm trained as the internal medicine physician, and in a previous life, a hospitalist, which is a critical care doctor. I also trained in psychiatry and have other trainings from UC San Francisco and UC Davis. And you know, we take care of about 40,000 lives in Marin County. And so we have comprehensive primary health care, specialty care, behavioral health that's integrated, dental and eye care. And it may not be clear to you, but I'm also an immigrant myself. I was born in Mexico City, and English is my second language. I actually dream in Spanish, and I'll tell you a secret, also in colors. And so you asked what it is, the greatest achievement that I have. You know, I don't know what to tell you. I think I'm living the dream. I'm a fortunate human being. I got an education, and you know, taking care of some of the most vulnerable individuals in healthcare for the last 35 years in community health centers is really a privilege. And it really is an honor to be here. And I appreciate being here today. And thank you so much.
Thank you, Dr. Chibras. Ms. Gray, Anne Gray.
Hi, everyone. I'm Anne Gray. I'm the CEO at Vivalon, formerly known as Whistle Stop. And my professional background is about 30 years in the nonprofit sector, and mainly in healthcare fundraising, medical research fundraising. So I bring an interesting perspective from that standpoint, and also from the organ and tissue donation world. One of my proudest achievements professionally is starting up a foundation for organ donation and tissue donation awareness, as well as support for the families of organ donors. And so that, you know, directly translated to, you know, multiple lives saved by educating people about organ and tissue donation and the importance of it. My most recent experience is with the Alzheimer's Association before joining Vivalon. And right at the beginning of the pandemic, there were so many different things that impacted all of our communities, but especially immigrants and refugees. And
estoy en mute, así que si quiere hacer ruido no
Priscila,
importa.
Priscila,
Sí, no, o sea, sí, estoy en mute.
Priscila, por
Todo
favor,
está
póngase en mute.
muteado. No me pueden ni ver ni.
Okay.
Priscila, sí,
okay, she's muted. But I'm really privileged to join you all today and look forward to contributing to the panel. So thank you.
Thank you. And now, last but not least, Marta Villela.
Hi, everyone. I'm glad to be here. I'm Marta Villela, and I was born in Guatemala and moved to the United States about 15 years ago, I think. So I had experience working in Guatemala in my field, psychology, but in the communities, working with our communities there. And here I actually worked with Vivalon as Hispanic coordinator. So that was a job that I really enjoyed, and it was, I believe, my first job working for older adults. And then I moved to Marin, IHSS Public Authority of Marin, where I also continue working with older adults, but also with caregivers. And all these years that I've been serving older adults, it makes me so proud of what I have done for them and all the services that I could accomplish throughout all these years. I think that's it.
Thank you very much. Well, as you all know, our topic for today is the disparities in healthcare among older immigrants. And I have prepared 4 questions, and the format that we will follow is that I'm going to ask question by question. I'm going to allow each of the panelists an answer to each question. Please keep your answers short because we only have 46 minutes, and I would like to go over the 4 questions, and also I would like to give our audience a little bit of time for questions. So then after each question, I'm going to open the floor for a couple of questions from the audience. And in order to keep up the conversation, I want to share with you the findings of an article called Health Disparities and Delayed Healthcare Among Older Adults by Dr. Du Yang and Sue Kingwin. This study took place in 2015. I'm sorry, in 2012. And this article surveyed almost 14,000 people aged 65 or older. And the findings of this article indicate that white people, regardless of country or birth, and US-born Asians enjoy better health than Latinos, African Americans, and foreign-born Asians. They also found that foreign-born Asians and foreign-born Latinos have the poorest self-reported health and mental health, respectively. So, having said that, the first question that I want to ask to our panelists is what are some of the disparities that immigrants and refugees find when getting healthcare, public services, or help from a community-based organization in comparison with people who are born and raised in the US? Who would like to start?
You know, I'll be happy if it's okay with the group. Hi, this is Dr. Chivitas. And, you know, that's such an important question. And I'll just, you know, I think we've already heard, you know, that the language barrier, not being able to access healthcare, especially in elderly folks. They usually speak their native tongue and it's really difficult. And they live in multi-generational households. So maybe or maybe not, the family members can help them access healthcare. You know, but what's really important to remember is that if you're an elderly immigrant or refugee, most will not have health insurance, and that's always an issue. And I think we've probably heard that. And, you know, the other thing that we see commonly with older folks who are coming into the US or, you know, for whatever reason, you know, sometimes they arrive with pre-existing conditions or they've had a surgery to a part of their body, a fracture, and the families are desperate to get them here. So they get off a plane and they show up for healthcare. They think they're going to get better care here. And it really is challenging to try and navigate the healthcare system in the United States with or without insurance. But if you're uninsured, it really is difficult. And, you know, one thing that's really important in this country is, you know, we've gotten out of the sick model of healthcare in the last century. In this century, we're in the wellness model of healthcare. At least we try to. And so folks who come here from other countries haven't had preventative care. They may not have ever had a colonoscopy. They may never had any cancer colon screening. They might not have had a PAP. They might not have ever had a mammogram. And so folks show up already with existing disease, and that's really an issue. We can talk about, you know, transportation insecurity, housing insecurity, isolation, and, you know, just not having access to dental eye care, behavioral health care, and, you know, most are not insured. So I'll leave it at that. So all those issues are incredibly challenging for immigrants and more so for a geriatric or older community. And, you know, we can talk about this for hours and days because it's complicated. Thank you.
Right. Thank you. Okay, Dr. Chibra. So you mentioned language, lack of health care, pre-existing conditions, and poor preventive care when they come from their own countries. Marta, what is your take?
Well, I have experience with my mom. She is an 86 years old lady. She moved to the United States in 2010. And she had previous conditions like doctor said. But she was getting treatment back in Guatemala. When she got here, she actually started depending on us, on her children, to get that health care, to get services here. Otherwise, I couldn't imagine how she could survive in this health system, because I feel like it's complicated. When she gets some services, she gets documents that are not in Spanish. And if we ask if there is a translated document, there is any excuse, we don't have it now, maybe we can send it, or right now we just need your signature. So there is confusion from these clients, the immigrants and refugees, who don't understand the system, who don't understand the language, and they need help with their health. But additionally, I would say there is also not just lack of English language, there are other languages that are not spoken in the health system that makes everything more complicated. And the cultural competency, how health employees treat them. Because most of the time they don't feel like they are talking to them, they are talking to their children. And then they don't feel like they feel like childs, being treated like child, like they don't have their own independence. And for instance, all those they already are facing changes in the societies and their cultures. I agree that they come from a culture where people just seek treatment when they are sick. There is no preventive care. I agree with that too. But when they get here, they also get depressed, and because of all those changes, the independency is taken away because of lack of language, because of the culture. That's from my own experience. So I agree with what the doctor said previously too.
Okay, thank you, Marta. So to summarize what you mentioned, you say that they don't understand the system, lack of cultural competency from the healthcare staff, and that this makes them feel ignored. Anne Gray, please give us your
Well, I would agree with my fellow panelists on every point. I think the language barrier is extremely difficult to overcome. And there's also some people might have distrust of the system or the doctors, or just bad experiences from the past that make them reluctant to seek out healthcare as well. And there's also limited knowledge of what services might be available to them, and making services available when there is a translator available so that they are getting quality care. They don't even know that that's something that they might be able to ask for as they're preparing for their appointment. So, and for community organizations, educating the community about all of these resources, when maybe we don't have people who speak that language, we have to recruit volunteers that we can train that can speak to their communities and help build that trust and educate about resources. And again, the diverse landscape of access to healthcare and transportation, and is it nearby and accessible for people who need it, is a huge issue. If they can't get somewhere on time because they don't, or in time because they don't have the right resources available to them, then that can also be an issue. But I do agree with the panelists that the main issues that all three of us have talked about are really the greatest.
Right. So you, of course,
I'm sorry, go ahead.
Así es, Marta.
I just wanted to add something that I totally forgot, but I know that you have to summarize what Anne said. So go ahead.
No, go ahead. What was it?
Well, just one point. The fear of getting public services because of immigration status.
Public charge.
Yes, there is many immigrants and refugees do not want to get public services because they feel like they won't they will get their documents to become documented instead of undocumented in the country.
Right.
Yeah, I meant
And,
to
you
say
know,
that too and
I
forgot.
and I think that links to what Anne said, that is a lack of knowledge about how the system works. Because in the case of refugees, they have full access to all benefits, and it does not count against them at all. So more so, it's lack of knowledge, like Anne Gray say, of how our system works. You also mentioned access to healthcare, of course, and the distrust of our healthcare system. Any question from the public? Any comments from the public before we move into the next question? Please raise your hand or turn on your camera, or you can raise your hand on Zoom, whatever works. Okay, there are no questions from the comments, from the public. No, the next question. Do cultural differences influence these disparities, and why? And before I dive into this question, I'm going to mention what the study that I spoke about during the beginning pointed out, that foreign-born Asians and foreign-born Latinos are the older minorities that have the worst healthcare system in our country. Why? Why these two? What cultural differences are taking a role in these communities having disparities in the healthcare system? Let's start with you now, Anne, please.
Well, I would say, in some cultures, it's really seen as a sign of weakness to seek out help and say that something might be wrong. People tend to keep it in the family, and out of respect for their elders, they won't say something's wrong, we need to go to the doctor, or someone may go to the doctor and say, come back and say everything's fine, when they didn't really ask the right questions in the doctor's office. And it just can really lead to a series of events that can be prevented. People tend to, they hold their medical professionals in high esteem in some cases and think, well, they're a doctor, so they must know more. And they don't ask the questions or advocate for something that the doctors may miss. And so, or through a cultural or language barrier, not be in tune with. So those are some issues that I think can lead to those types of disparities. And also in medical research, which is a lot of my background, things aren't explored in people of color or people from different races and different ages. It's all kind of a very finite group, and then it's not tested widely, and having more people who, in the instance of Alzheimer's disease, Blacks are twice as likely to get Alzheimer's, and Latinx population is about 1.7 times more likely to get Alzheimer's, but no research is done on those communities. So that is something that the research community is trying to change, is to increase diversity in clinical studies, and hopefully that will translate to better care for every community.
Thank you. Marta.
Yeah, I think the cultural part is very important because, for example, here, everyone has to have a health insurance, while in many of Central America, people do not need a health insurance. They just go to a hospital and they get services without paying a cent, unless they request something as a payment, like donates blood or something like that. So when people come,
lack of universal healthcare, Marta, is that what you're referring?
Yes, but when people come here, And let me share my experience. The first time I got sick here, I didn't know English, so my brother was with me at the hospital. He brought me to a hospital in Marin. And I thought, wow, the services here are very good. And I felt very like the care that they were taking from what I was suffering by that time. However, I got just, the prescription was to take Tylenol. So I felt like, okay, I think I spent my time for nothing. I expected something better. And I thought, well, probably it's free like in Guatemala. So I went back to my home, and a couple of weeks later, I got the bill. And I was thinking, oh my God, now I have to pay $700. Seriously, just to get Tylenol that I actually bought at the pharmacy? So the cost of the healthcare, I think that also makes people to think more than twice to go to get a doctor, to be seen by a doctor. That's my point of view. But another one is also, again, preventive medicine versus curative medicine, because people, if they are sick, they will go to the doctor. And a lot of men in Latin America, they feel so brave, that like macho men, I'm not getting sick, I'm okay, I don't need to see a doctor for preventive care. So until they are really sick is when they go to the hospital. So I think that's also part of the culture, and it makes it difficult. And so then people, there are others like Mayans, they might seek for remedies or alternative medicines, or Asian people, they might see their Asian doctors.
Right.
Right.
Right. So you are saying that lack of universal healthcare, because a lot of these immigrants back in their countries, even if the healthcare is not the greatest, they can at least go and receive free help. The stoicism that some cultures have, like, oh, I need to suffer alone, I'm strong, if I ask for help, people are gonna see me as weak, and how some communities prefer to use an alternative medicine, right? Okay, Dr. Chibras, your turn.
Thank you so much. And, I'll just share with you some experiences that are very clear with disparities right now. And that's, in Marin County, 1 in 3 individuals in the community are over the age of 60 years of age, and 1/3 of those individuals live alone. If we look at, some of the immigrants or folks who are refugees, you look at the canal, we have multi-generational families that are living together. And so what does that do? That begets, crowding begets diseases. COVID's one example. I don't want to bring it up. I don't know if we need to bring it up, but I mean, it affects essential workers. So, grandfather and grandmother are living with the kids, and they bring it to them, and they end up sick, and they end up having to go to the, to the hospital and the doctor. Now, typically, the reason I bring that up, I wanted some examples. Some examples are not with COVID. Somebody gets an infection in their toe or their leg, and some cultures are used to trying to treat themselves. And so what they do is they typically, in other countries, just might go to the pharmacy, and the pharmacist will give them some advice, and they'll purchase the antibiotics, and they'll treat themselves. And it's an injectable penicillin or pills. And I have to tell you, in Marin County, this happens every day. Folks will go down into little family stores, and somebody behind the counter will prescribe for them, without a license, antibiotics. It's not uncommon for folks that are treating themselves with injectable penicillins or taking, antibiotics that were given to them, and I'm going to say it quietly, illegally, because it's not legal in this country. And I don't judge folks, but it's the wrong thing to do. And the person who's behind the store, I don't know who it is. I don't know. It's not a pharmacist. And I don't know who it is. So people are self-medicating themselves because of everything we've talked about. They may not be able to afford healthcare. They know the Tylenol that we're talking about, usually an ER visit might cost you $5,000, $10,000 for something if you've got something. And so they'd rather go to the local store, literally the local store, and purchase some antibiotics or some medications, or, try some home remedies. And sometimes they work well for things that aren't serious. Sometimes, folks don't show up to the ER until they've tried themselves, or they come to our community health center to get some care. And I just want to bring that up. The other thing that's very cultural is, behavioral health or psychiatrists. A third of Americans, third of individuals that have diabetes, whether you live in Tiburon or in Belvedere, have got some kind of dysthymia, early depression, if they've got a chronic disease like diabetes. Well, we know that Latinos and a lot of folks, are predisposed to diabetes. Closer to 12% of the population for Latinos versus 7% for those that are here. And so that begets eye problems, heart problems, and they're depressed, and they will not seek out care for other reasons. We've heard it's just not macho. It's not something that's accepted that tells somebody that they need to see a therapist. It's very, very common. In fact, it's actually quite cool to have a therapist if you live in Belvedere, to tell all your friends that you've got a therapist because you can afford one. And so, those are a couple examples about disparities. If you take a look at the Brookings Institute, some studies in 2020, some of the statistics for life expectancy, which are huge. I mean, Marin County has the number one life expectancy for women and number 5 for men. And that's not for immigrants, and that's not for homeless folks. Homeless folks live 30 years less than the average human being, just because of everything that goes on. And we haven't talked about stress. Stress kills us just like anything else, like a handgun or getting hit in a motor vehicle. It just kills you slowly and you just decay quickly. It begets a lot of illnesses like hypertension, diabetes, and depression. And so some of the disparities that we have are different. You're probably a little bit more comfortable in your native home when you're here. It's stressful to try and get down three flights of stairs. And this is not cultural, but you might live on the 3rd floor. And if you're 80 years old, you're not leaving that building because they'll never get you up the stairs again. So,
Correct.
And you might tumble down the stairs, but I'll leave it at that. But thank you so much.
No, Dr. Chibras, I think what you said is very true. I myself was born in Mexico, and I lived in Mexico until the age of 18. And it was very common for my family and I to go to the pharmacy. And the pharmacist would give us antibiotics, and we would rarely see the doctor because we would just go to the pharmacy. So that is very, very true. Thank you for pointing that out. Now let's go into our third question. And now we are going to be talking about more day-to-day problems that older immigrants face. The next question is, how do these disparities that we've been talking about, how all these cultural differences that you all mentioned affect the quality of life of older immigrants and refugees? Now let's start with you, Marta.
Well, I think for an immigrant, moving to the US is already a challenge, especially for older adults. I could see that with my mom, how she experienced the change coming from a society that she was already used to, and coming to a new society where she actually felt isolated because of the type of society, because of the lack of language. She was unable to communicate with neighbors other than her children when they come to visit her. There is so many changes in their lives that affect them, affect their health, and that can cause not just isolation, also depression, anxiety, and these challenges really made them feel more dependent on someone. It could be a child, it could be another relative, there is someone else. But I was also thinking about those older adults, immigrants who came a long time ago, and they are still facing kind of the same issues now after probably 30 years, that they couldn't learn the language really well. They were living under the poverty line. and they're still facing those almost the same health issues. And let me tell you that even though my mom doesn't know English at this point, and she tried to learn it a couple years, but because of her memory, she couldn't learn it. She still is able to join yoga classes without saying a word, just smiling. So yeah, it is challenging, but I think she couldn't navigate. And again, it's hard for them to understand the system. They get information that they don't understand. And they don't have, sometimes they don't have any other place to go to get those documents ready for them to understand what is their situation. If they are in a clinic, most of the time, if there is a child, if the child knows well English, the child will be able to help them to understand and also ask questions. Otherwise, both the child and the older adult will be lost because they don't understand what is the plan from the doctor. They don't understand what is next, why they are prescribing a medication. They just take it if they trust to that doctor. I think that's my response.
Thank you. Dr. Chibras, your perspective, please.
Sure, thank you so much. The we've already talked about morbidity and mortality. It's definitely increased in immigrants and refugees for all the reasons we've talked about. And the increased stressors of just being here are incredible. We've talked a little bit about ICE or immigration and the fear. It's difficult to want to take grandmother or anybody to a church or to dinner when you're worried that maybe you won't come home, and that maybe some of us don't understand that, but it's real. I mean, I can tell you I've been pulled over and been asked for documents in San Diego as an adult, as a doctor, and been asked questions, asking me all these questions. And it's like, leave me alone. Do you want to speak English? Once I speak English, they go, why were you speaking in Spanish? Because you spoke to me in Spanish. And never mind, and Spanish is my first language. So it's like, oh, you're bilingual. Yeah. So anyway, so fear that, food insecurity is huge. Food deserts are a big insecurity. The cost of living in Marin County, it's the most expensive place in California to live. And I already talked about multi-generational households. And, it's not okay for 9 people to live in an apartment with 2 bathrooms. And if there's 3 bedrooms, there's probably 4 families, 1 in the living room, 1 in each bathroom. And I don't know if any of you or any of us can really understand how difficult it is to live in that kind of a situation for privacy, for anything, how it is during COVID, how that affected the entire household. There's lack of health care, but we didn't talk about dental care, eye care, sight care. All those things are really, really important. And I'll just give you a quick little example of quality of life and how simple things that should be simple are so incredibly difficult. When my mother used to take us to elementary school in Los Angeles, because we were immigrants, she would get up early in the morning, there were 4 of us, and walk about 45 minutes to an elementary school. Every morning we had to get up and walk because we only had 1 car like everybody else. The family might be lucky to have a car in the family between several families. And we'd walk to an elementary school. And one day a lady stopped my mother as we were coming home from school. And she said, I see every morning that you walk early in the morning. And the reality is that my mother was taking us to a school that was about, maybe about 3 miles away from home. And she said, do you know the 2 blocks behind you, there's another elementary school. Why don't you register your kids there so they're 5 minutes away from school? Well, my mother did this because she didn't know. And nobody told her. She's an angel. She had to get up in the morning and take us to school. And walk us home. And that was difficult for her. And so these things happen to all of us as immigrants in lots of different ways with grocery stores, trying to find a grocery store, a pharmacy, a school, a high school, trying to get help for anything. And so, we're blessed. We're absolutely blessed to have all these individuals in Marin County who are out trying to help folks, because simple things like making your mother walk 2 hours a day to take you to school when the school's next door is really, it shouldn't happen
Correct.
in this country. It shouldn't happen anywhere in the
Correct.
world. So thank you for letting me share.
No, thank you for sharing, Dr. Chibras. Thank you very much. Ms. Gray, your turn.
Yeah, I think that, really it comes down to, people are suffering in silence. It's just, Dr. Chibras's story is exactly that. There wasn't someone that she could reach out to and say, my kids, school is so far, what do you know? Where do your kids go to school? That sort of thing, because maybe, I'm sorry to make assumptions, but maybe the neighbors didn't, embrace, the way people talk in neighborhoods. Maybe everybody in the neighborhood kept to themselves. I know in my neighborhood growing up, everybody kept to themselves. They didn't, check in on their neighbors, and that's changing, I think, today to an extent. But that isolation is so damaging in every phase of life, and with suffering in silence, whether it's because you're afraid to get care, or because you don't have a circle to reach out to get information. I think those are really sad things that can be changed. And I really feel strongly that communities need to come together and not just, stay behind their doors to help one another, because you just never know what's happening in the house next to you.
Aaron, sorry, I just forgot to mention something again about jobs, the job opportunity. When an older adult feels like they are still able to perform a job, there are some doors that close to them. And I've seen that, especially with our caregivers at Public Authority of Marin, we have older adults willing to take care of older adults. And when we refer them, we know that there are some clients who need the help at home, and they're still looking for young caregivers. When we refer the old ones, they complain, saying, why you are sending me this elderly if I'm an elderly? I feel like this person needs more care than me. So that's the reality in our society, in our community, where people need help, but when they have an older adult willing to take care of them, they are discriminated because of their age. Right. And I believe that happens not just in this field, it could happen in other fields.
Right. We have 13 minutes, and I think we have time for an additional question that just came to my mind. And I would like to get your input when it comes to this. Vaccination access. Do you believe that these disparities that we have talked to have had anything to do with access to the COVID-19 vaccine? Dr. Chibras, your perspective.
I'll be happy to answer that. Fortunately, Marin County is #1 in 58 counties in California for the number of vaccines that have been delivered in our county. And we've been #1 in the United States. So we've been an exception. And I can tell you at Marin Community Clinics, we made very, very early commitments in February to make sure that all the individuals that were in areas like the Canal or Novato or anywhere in Marin County where there's disparities, that we didn't have disparities. If we look at the numbers today, the number of vaccines that have been delivered for fully vaccinated Marin County residents is over 91%. If we look at somebody who's received at least one shot, it's 98%. If I take a look at the Asians, the African Americans, the Latinos, and the whites, we're all exceeding whatever everybody else is doing in the country. So I'm going to tell you, we were vaccinating folks from 8 in the morning until 8 at night, Tuesdays through Saturdays, getting home at 9 o'clock at night to make sure that there weren't disparities in our community. I can't say that in Missouri or in Texas or in Florida and other states, but we can tell you, we'll be proud that with the partnerships that we have with the hospitals, with the county health department, our county health departments have been very clear about making sure there weren't disparities. So I can tell you that I'm very proud of the number of folks that we did vaccinate and continue to vaccinate, and are given boosters as well. So get your vaccine early and often in Marin County. Let's get out of this pandemic. Thank you.
Yeah, Dr. Chibras, and I actually can attest to what you said. I was the executive director of the public authority when the vaccine efforts were rolled out back in January of, back in December of 2020. And I sat in different commissions and task forces. And yes, Marin County did an excellent work, an excellent job since very early to make sure that these disparities were not as pronounced. But what about you, Marta? You have been helping, especially IHSS caregivers, get the vaccine since very early in the pandemic. What is your take on have these disparities affected the access to the vaccine?
No, I don't think so. I don't think so, because there was a lot of efforts from the public health community clinics. I also saw some during pantries, the community clinics were providing information. The public health was in touch with churches, with bring to go at the beginning. I think it was just that everyone had to go to a certain place, but then that program expanded to the whole community, because I believe that the public health was interested to get the vaccine to most people as possible to control the pandemic. So I don't think so. I think there have been a lot of efforts to cover most of the population in Marin. I think it's just that in our community, many people gossip about false information, and for probably to be illiterate or without having facts about the vaccines, people just made a decision not to get the vaccine. That's the only issue that I have seen in the community.
And has that been your experience, or do you have a different opinion?
Well, I agree that Marin really rose to the occasion to address disparities. Start of COVID happened in Southern California, and then coming up here. Really, I feel strongly that COVID just put a spotlight on inequity and disparity that's existed all along. And because of the nature of the crisis and the intensity of the crisis, people were able to spring to action and help these vulnerable populations. And it's a huge concern of mine that, once the spotlight dims and hopefully we're out of the pandemic, that these efforts don't, that they continue, let's say.
They continue.
That we always are thinking of other communities and inclusivity in every decision we make about healthcare. As far as disparities right here in Marin, I mean, we really saw people without access to the internet. How do they make their vaccine appointments, other than word of mouth and coming to, Marin Community Clinic and different things. And so Vivalon was able to work with the county and set up a call line where we did almost 16,000 robocalls, and people could call the number back, and we had a language line that would help them if English wasn't there or Spanish weren't their primary languages. We had Spanish speakers right in the call center as well as English, but any other language, I think there were 200 languages in this language line. They could help them and make the appointment for them. And so just remembering that these inequities have existed all along, and the way that we've been able to rise as a community to address the pandemic, we need to rise in that way for all areas.
And actually, you're absolutely right. Marta, you know what I'm talking about, the public authority. Also, we put, along with the county, with Aging and Adult Services, we put a hotline for not only the IHSS caregivers making appointments, but also for recipients. So we went above and beyond to ensure that our population had access. So what I hear from you all is that, yes, Marin County has a lot of disparities when it comes to healthcare, but when it came to the vaccine, the entire community got together and went above and beyond and did great things. Now, that doesn't mean that maybe in Fresno or Stockton or Texas or Missouri, like Dr. Chibras said, there wasn't or there isn't any disparities over there.
Let me just tell you one thing. This is really important. Most of our patients have flip phones, if we're lucky, and or don't have an email, especially when we started in this 75 and above. And so we had to get with the county health department. The Fed set up a system for somebody for Silicon Valley who's techie and is really a techie, you know, some kind of a geek. So what we had to do is everything you're saying, we had to set up appointments, and our staff had to get everybody online and sign up the families to get, you know, everybody in, just like what you said, Monday through Fridays or Saturdays, and make sure that there wasn't a digital divide. Additionally, another thing is, I don't know if folks know this, you know, Kaiser's been using telephonic visits, video visits, you know, for a decade, and federally qualified health centers have not been able to do that or provide that service. And we've been working with NAC or, you know, the federal government or CPCA to make sure we did have the ability to be able to do this. And we want to continue to be able to provide video conferences. That's not okay for us not to be able to do what everybody else can do, but now we can, and hopefully we will continue to do video visits for folks and, you know, for behavioral health and everything else. And I'll leave it at, the system was not set up. It was very myopic. It was not set up for the majority of the folks. It's definitely not for immigrants or refugees or a geriatric community.
Right, thank you. I was just informed by Linda that we actually have until 3:10 because I think the keynote speaker is running a few minutes late. So we still have a few more minutes. So that gives us time to do our fourth question, and then we are going to close with in the last remarks from all of our panelists. Our last question is, what is your organization doing to alleviate these disparities that we spoke about, and what more can be done? And let's start with you.
Well, I think that for Vivalon, in addition to what I just mentioned in the prior question, you know, we welcome everyone here at our Active Aging campus, and we are very attuned to what's happening in the digital divide and addressing those things as well. And we're very sensitive to the needs of older adults in all of the communities in Marin, and have worked with the county on, you know, culturally appropriate meals for meal delivery and for congregate meals, so that people in, you know, all parts of Marin are getting proper nutrition and food that they will eat that's nutritious and tailored to their culture and taste. And so always thinking in ways of, you know, it's not one size fits all, and how do we customize services so that people will take advantage of them, and that they feel comfortable, and that they have an affinity to and a support network and connection in ways that are familiar and comfortable for them. So that's always top of mind for us.
Thank you. Dr. Chibras.
You know, Marin Community Clinic serves 40,000 residents of Marin County, and we see over 250,000 visits annually. And we provide comprehensive primary health care, which is internal medicine, family practice, OBGYN, and pediatric services. Do about 1,000 deliveries in the hospital at Marin Health. Our pediatricians around there. We have dental services at 4 locations that are open until 9 o'clock at night. And I 7 days a week. So Sundays, you can see our folks. We have integrated behavioral health. We have adult and children's psychiatrists, psychologists, LCSWs. We have a complex care team that takes care of the most vulnerable individuals. We have in-house pharmacies. We have 3 in-house pharmacies in Green Bay, San Rafael, and Novato to make sure everyone gets their medications. And by the way, the Tylenol will not cost you $700. We make sure that we buy it through the federal government, through federal pricing. And so we're able to beat anyway in the county. We have 28 other contracts with other pharmacies. We have in-house x-rays. So if you need to have an x-ray or radiology services, we do it in-house. So we don't send you out to the hospital so you get that huge bill. We also have specialty care. We partner with UC Berkeley to make sure that everyone has eye care. We have 2 eye clinics with UC Berkeley. Their faculty works with us. Their students rotate through with us. And more importantly, we have cardiology, dermatology, orthopedic surgery, podiatry, rheumatology, physical medicine and rehab. And I'm probably forgetting 4 or 5 other things, including nutrition and alternative care in terms, chiropractic and acupuncturist. And so we also provide food to over 1,000 people every week, 500 at each location. You know, pharmacies are important, but food sometimes is the most important thing that we can do for individuals. And most of our staff, almost all of our clinicians are bilingual or trilingual and definitely speak Spanish. Our MAs, our nurses, we try and hire everyone who at least speaks Spanish. We also, by the way, legally, you should be able not to have a child come into the exam room like my family did when we went to the hospital and translate for our parents when we were kids. That's not appropriate. We have language lines, which is the law, and everywhere you go. So you shouldn't have kids talking delicate or trying to interpret for physicians. There's a language line, whether it's for Chinese in different languages, or if somebody's from Germany or Cantonese or whatever language that they, Farsi, they should be able to translate. So we make sure that we've done that as well. And what else can I tell you other than we're open 6 days a week and evenings? We want to be available, like I mentioned, dental on Sundays because people work on Saturdays. And so, we also have committed ourselves to ACEs and making sure that all of our staff and our patients are being screened for adverse effects of childhood, which we know are very important. And hopefully that we practice empathetic caring. And one last thing that you have to know, in the United States, Marin Community Clinics is in the top 10 percentile for all the community health centers of 1,400 of those clinics. And in Northern California, we're usually #1 for health outcomes. So we see a lot of folks, but we also practice real high quality medicine. And I appreciate you letting me share that.
Of course. Thank you. Great job, Dr. Chibras. Marta, what is the public authority doing to alleviate these disparities?
Well, we already help or serve, like, I would say 900 recipients who receive care from our qualified caregivers. These caregivers help them to remain independent, and they also come with them to the doctor's appointments. We try to provide the training that they need throughout the year so they can provide that service with quality. And in our office, we are a short team. We are 5, and most of us are bilingual. So make sure that we can provide bilingual service, at least for Spanish and English speaking recipients and providers. In addition to that, talking about quality of life for older adults in our county, we also provide opportunity for those older adults who still are looking for a job. We gave them the opportunity to be in a registry of referral lists so they can remain active and working in the community.
Thank you.
Mm-hmm.
We have 7 minutes before we go into our break at 3:10. Does anybody from the public, from our audience, have any questions for our panelists, any comments, etc.?
I have a question.
Yes.
My name is Julia Van Solen Kim, and I'm with UC Cooperative Extension and with the Marin Food Policy Council. And so I really appreciate the brief references to the important role that food access and culturally appropriate foods play in people's health outcomes. And I'd love to hear any more information people have in terms of the role of food access or insufficient food access, food insecurity amongst immigrant populations in terms of their disproportionate adverse health outcomes.
Who would like to answer that question?
Since I brought it up before, I'm happy to address that. Well, not happy because it's an issue, but you know, it's very challenging for people to have access to the healthy foods from their cultures because they're very expensive here too. I mean, that's another issue that has to be addressed, is people might not be buying the most healthy things if they do have the ability to go and shop. And so looking at, you know, as a society as a whole, as I was saying, you know, it's not a one size fits all. And one of the things that we do here at Vivalon is we have a brown bag pantry every Friday. Anyone from the community in need of food is able to come in, and how it's set up is that they can select their own food. It's not just packaged and given to them. They can make an appointment and come in and get their own food. And that way they can select the things that are healthy, but that they will eat, so that there's not food waste, and there is the ability for them to make their own choices for things that would be more nutritious to them. And again, it's a matter of making people aware of these services, and it's a matter of you know, the foods from different cultures, you know, having those healthy pieces in the education about what the healthy food is, not just to an American diet, but to a multicultural diet, I think is something that oftentimes we miss the mark on. We talk about, you know, eat healthy, this and that, but what does that mean to different cultures? And we need to customize those messages because food is medicine, you know, in so many ways.
Right. Thank you, Anne. Pamela, you have a question. Please unmute
I don't have a
yourself.
question. I want to follow up on the food insecurity. Marin Community Clinics has health hubs, what they call health hubs, in Novato and San Rafael, where there's weekly distribution of food that's donated to them, and the vast majority of it is whole foods. And so this is food either from the food bank or from direct services, where people can, while they're visiting the health center or come on those particular days, and get enough food for the different members of their families. And sometimes during the health hubs, they also have a person who works with nutrition who provides you with like a little, very simple, easy to make recipe at home for how to use some of the foods that you've taken with you. And there's a great diversity of the foods that are available. And I'll close with this. When I visited to help staff and give information about health insurance during a health hub, I am astonished at how many seniors are on the edge and financially insecure who depend on that service for their food needs.
Right.
Eric,
Thank you.
let me comment and just follow up about our health hubs. And that's what I was
Yes,
talking
please.
about, giving 1,000 folks food. Weekly, we give 500 folks in San Rafael and 500 in Novato weekly. And we could do a lot more, but just because of the pandemic, we've had to, you know, socially distance people, pack things up. But before the pandemic, we used to have cooking classes. We had free health hubs where we'd have a doctor or a PA that was doing blood pressures and free of charge checking blood pressures, or making sure folks weren't diabetic. And literally we would even cook and have recipes to show them, individuals with perishables or non-perishables, what they could do with those foods. And what is true is that, you know, sometimes it's sad, but if you've got Medicare and you have to decide whether you're going to buy 4 different types of medications, or you're going to buy food or pay the rent, sometimes people choose difficult choices, maybe pay the rent, maybe pay their light bill, and they don't purchase food, and they cut their pills in half and they don't take their pills. So, you know, food is so important. And also food deserts, or places in these little stores that charge like 7-Elevens 5 times more for milk, and I'm making that, maybe it's twice as much, instead of, or whole paycheck where you can't go in there anyway. But finding a place that's affordable and fresh, you know, produce and vegetables are probably the most important thing that we can do. And I thank that person, whoever it was, I'm sorry, I don't know who you were, for letting people know what Marin Community Clinics is doing about food insecurity.
Right. Well, it's 3:09 and we are about to break for our 10-minute break before we go in with the keynote speaker. I want to say thank you very much to Dr. Cibras, to Marta Villela, and to Ann Gray for their time and for sharing their expertise with everyone. It's been a pleasure to moderate this session, and the convening is going great. So thank you also to all of you that joined us, and we'll see you in the keynote speaker session. Have a great remaining of your day.
Thank you,
Muchísimas
Aaron.
gracias.
Aaron.
Hasta luego.
Bye, hasta luego.